So, yeah, so I'm a neurotologist. I've been practicing in private practice for about 14 years now. A significant portion of my practice is dealing with chronic ear disease. So that means cholesteatoma, chronic suppurative otitis media. So in those years, the two developments that have made the biggest impacts on my practice, first is the introduction of otoendoscopes, primarily for treatment of cholesteatoma. And then the second has really been the ability to dilate up the Eustachian tubes. So chronic ear disease, far and away the number one underlying cause is untreated Eustachian tube dysfunction. So also it follows that the number one reason why surgery for chronic ear disease fails is also untreated or unrecognized underlying Eustachian tube dysfunction. So being able to address that has made a huge difference. So, what's the advantage of dilating versus just the tried and true putting a tube in? Well, the biggest, most obvious difference is you don't have to make a hole in the eardrum because, as all of you have probably experienced, sooner or later, that hole may not heal or it may expand, and you've basically, in trying to treat your patient, you've created a portal for bacteria and infection, and sometimes even for squamous epithelium to migrate through, and then you basically have set yourself up for a future cholesteatoma patient. So what are the disadvantages to dilating? Well, the main one that I can think of is that it's only effective in about 75 to 80% of patients, whereas tubes are 100% effective, but just for a short period of time until it clogs or it extrudes. So in my mind, there's not a huge disadvantage to dilating other than maybe difficulties with getting it approved by insurance. So I'm going to talk a little bit just about my experience with it. Just by a show of hands, I'm curious how many of those of you out there are doing balloon dilation? Okay, so good, about half, so a fair number. So when do I consider dilation? So for chronic ear disease, again, we're talking about chronic otitis media, suppurative, and cholesteatoma. Number one, if I get patients referred who have failed previous tympanoplasties. So for those patients, I'll try to get a history and see if I can elicit any history of chronic Eustachian tube dysfunction, like they've had tubes or they, prior to the perforation, they've always had trouble with altitude changes and air travel. For those patients, I will discuss dilating the tube before I go back in and do a revision surgery. The second one is for patients I get referred who have a recurrent cholesteatoma, specifically ones where you see a retraction pocket. Those patients would definitely benefit from dilating. And in my experience, if you dilate up those patients and assuming that you remove all of the disease, it's cut down on my revision rate by at least 50%, if not more. So pretty successful. The other downside to dilation is because it's relatively new, I think it's been FDA approved for a little over 3, maybe closing on 4 years at this point. We don't have real long-term data on whether or not you need to dilate just once or you have to go back again. So in my experience, I've been doing it now for just about as long as the FDA has approved it. I'm finding that probably about 1 or 2% of my patients I will have to take back at some point and dilate. And for those patients, it's usually the 2 to 3 year mark. The other part about dilating, in patients that are unsuccessful, there's still some controversy as to how effective it is if you go back a second time to redilate. So, but for revision patients, if they have that history, it doesn't hurt to at least give them a try because otherwise, they've bought themselves a tube. So the other time to dilate is obviously if they've had multiple tubes and you're dealing with a perforation that's enlarged. Those patients, you should at least try to dilate and see if you can get by without having a tube placement in the future. You probably have all encountered implants that basically the eardrum retracts and you've got this implant that's sitting proud and eventually it extrudes. So for those patients, they're also very good candidates for dilation. And the last patient that I will see very commonly is if you have glue ear or tympanic atelectasis. And I have a little case a little further on that discusses that. So the workup, pretty standard. I always do audiograms, definitely get tympanograms. You need to document that they have eustachian tube dysfunction if for any reason, mainly to get it approved by insurance so that you can actually do it. I always do a microscopic exam, and as part of that microscopic exam, I always have the patients do a forced Valsalva. Because sometimes you can see a retraction pocket that actually is not due to ongoing eustachian tube dysfunction. It's just sort of a sequelae of the past, and so it's actually just a flaccid segment. So those patients, they blow, you will see that retraction pocket evert. So always do a Valsalva. I always do a nasal exam with endoscopy, and that helps you in two ways. Number one, you rule out extrinsic causes of obstruction in the nasal pharynx, so things like hypertrophic adenoids, sinus disease, mass, skull-base mass. The other reason to do it is it actually helps you in your preoperative planning. So you need to be able to get back there with both the dilator and the camera, and so it gives you a preview of the nasal anatomy and helps you to plan the procedure. If the patient has other causes or comorbidities for eustachian tube dysfunction, you should at least try to treat those first and then have them come back and see how they do. So if they have sinus disease, always treat that first. If they have allergies, smokers. I do not dilate up smokers unless they have quit smoking because it will not work. The mucosa is hyperemic, their ciliary clearance isn't normal, and so manage underlying medical disorders first. There is some controversy as to whether or not you need to do a CT scan before dilation. I'm just curious, if you can raise your hands, how many of you routinely order a CT scan before you dilate? Okay. So there's no clear guideline yet. I would get a CT scan if you're concerned that there's chronic ear disease. The controversy, though, is really with carotid dehiscence, right? Because the internal carotid artery, very close to your dilator, and so if you have if you have a aneurysm, if you have a dehiscence, there is a chance that you can dissect. So in the literature, there are a lot of studies that have looked at what is the incidence of true carotid dehiscence, and it's actually pretty low. And if you look at the FDA reporting system for complications related to dilation, there's only been one report of a dissection, and that's in looking at it from, I think, 2000 to 2022. So it's pretty low. You're not wrong to. I always counsel my patients that could potentially be a risk of dilating, but I don't routinely order that unless I'm looking for something else. But that is up to you. So when not to dilate. So I usually reserve it for chronic ear disease. So acute eustachian tube dysfunction, less than 3 months, and it's really they have no really other history of that. If they have no other history of that, I usually will watch it or just place a tube because then you can remove it and it saves them a procedure. A patulous tube, it won't work. In fact, dilating can actually cause a patulous eustachian tube. And then other causes like external obstruction. So just some surgical tips. Dilating is actually technically really easy, but I usually use a 30-degree scope. It helps me to kind of stay out of my own way so that I can have extra room to pass the dilator. For patients that have a significant septal deviation, sometimes what you can do is you can actually use a 70-degree scope, pass it through the contralateral side. So I'll use a 30-degree scope just to basically help me place the dilator in the nasal pharynx because you don't need to go all the way back, and so you still have a lot of room for that. And then you withdraw that and you pass the 70-degree scope over to the other side, and you use that to basically guide your placement into the eustachian tube. So that works as well. How many of you do the dilation under general anesthesia versus in office? Does anyone do it in office? Okay, all right. Well, I'll have to talk to you. I usually do it under general anesthesia. I think the patients are more comfortable. I'm certainly more comfortable when they're under. And it also allows you to be a little bit more, slightly more aggressive with manipulation. So I always tell patients beforehand, I may need to outfracture the turbinate to gain a little more room. And then lastly, sometimes you just have to kind of bite the bullet and do a septoplasty. So complications, dilation is actually quite safe. There's in the initial FDA clinical trial data, there were no major complications. The most common one reported is a nosebleed. I haven't had any, and usually it's because if you see a nick, you just take care of it with cautery at the time of the procedure. I do see about 1 to maybe 2% of my patients will develop a patulous eustachian tube afterwards, and these are patients where they could never equalize with a Valsalva, and so I'm pretty certain that their eustachian tube was closed beforehand. And so in those patients, it's sort of an annoying symptom, but usually it's very self-limited. So if you wait about 3 to 6 months, usually by 3 months it starts to get less and less, and all of my patients by 6 months, it's resolved. So I haven't had any permanent long-term patulous patients. Does anyone ever treat it? In those of you who have done it and who've gotten that complication, have any of you treated it? Yeah, no. Yeah, it's usually pretty mild. I haven't had to either. There are reports of patients getting subcutaneous emphysema and pneumomediastinum in the literature. There are actually, I think, 10 cases that were reported to the FDA, and I haven't encountered that, but the mechanism, if you look at those patients, it always occurs during the first 3 days after dilation, and those patients are doing vigorous Valsalva, either because they were told to or because they just want to clear and see if it works, right? And so, or strenuous exercise, again, leading to Valsalva. All those cases, they were managed expectantly and they got better. So that's a pretty, I do discuss with my patients, it's pretty rare. And then carotid artery dissection, theoretically possible. I think in the FDA reporting system, there was like 1, and that patient needed to be stented. All right, so I'll quickly move on to cases. So 41-year-old male referred for conductive hearing loss. On audiogram, there is an airbone gap with 15 to 30 decibels of conductive loss. There is a Carhart's notch, type C tympanogram. On exam, you basically see the tympanic membrane completely plastered down to the, into the middle ear with a little trace fluid, and you can beautifully see the outline of the stapes. You do a nasal endoscopy, and it is normal. So these are the options. So I'm going to have people raise their hands. How many at that point would place a tympanostomy tube? Anyone? No. Okay. How many would do cartilage graft tympanoplasty and then place a tube through the cartilage? 2. Yeah, that's that's pretty classic, tried and true, very reasonable. How many would perform eustachian tube balloon dilation? Show of hands. Anyone? And would you do it alone, or would you do dilate and then with a planned tympanoplasty? Yes. Is that? Completely plastered. It's all the way down. Like you can see, the air cells basically. Yeah, yeah. So and then D. How many would dilate first and then perform a tympanoplasty? Show of hands. Okay. Yeah. I think the correct answers there are B, and what I would do is D. So placing a tympanostomy is just not going to work. When it's really atelectatic, it doesn't even need to be completely plastered down. You can kind of see it. It's adherent. The tube's not going to work for that patient. For the same, and along the same vein, if you just dilate up the tube, it also won't work because you won't release that eardrum and it's permanently damaged. It's thinned out. Yes, question?
Does the opacity make any difference to your management?
No, actually. Each side is independent. If the patient has less severe symptoms on the other side, then at that time I'll probably dilate as well. But if it's a normal ear, I don't dilate just in case, because more often than not, you're going to get a patchless tube afterwards. Okay, yeah, so B or D. So my last case, I don't know what that is. So last case, 35-year-old male. I'm going to do that. Okay, that's better. So you can still hear me? So 35-year-old male presents with right chronic otorrhea for about 10 years with hearing loss. He's referred to your clinic. He's had tubes before. They always fall out. Hearing loss recurs. His audiogram, you see a mixed conductive hearing loss, air-bone gap, pretty much straight across the board, 30 decibels. On exam, the tympanic membrane is moderately retracted. There's no distinct retraction pocket per se. It's just the pars tensis pulled in. There is a pinpoint perforation, and through that perforation, you get a thick but non-purulent mucoid effusion. So you do endoscopy, and it's normal. Okay. So your options for this patient, how many would go ahead and dilate up the Eustachian tube? Show of hands? No one. Okay. How many would place the tube and dilate at the same time? Show of hands? All right. How many would just test for allergies and do a trial of steroids, see if they get better? Okay, 2, reasonable. And then how many at this point would just get a CT scan? Show of hands? Okay, all right. So I chose to get a CT scan, and my rationale was this has been going on for 10 years. I wanted to and the effusion is not just serous, it's pretty thick and proteinaceous, which means that it's been sitting there for a while. And oftentimes for those patients, they're gonna have some mastoid disease as well, or they can have attic block, basically just granulation tissue blocking the flow of, oh, sorry. Yeah, I was getting some kind of interference there. So some of these patients, they will have chronic mastoid disease. So I chose to get a CT scan. And so interestingly enough, this is what the CT scan shows. And the obvious abnormality there is you see these metal fragments right next to the petrous portion of the internal carotid. And so I was kind of surprised. This I was expecting to see, mastoid disease. This I wasn't. So I went back and I asked the patient, I was like, so, what is that? And so he said that, well, when he was a young man, there was a attempted mugging, and they shot him in the face. And, yeah, oh, and by the way, exactly, he was a teenager, and the only visible sign, was this tiny little scar on, the lower side of his cheek. And so for that patient, dilating obviously is not going to work. But what I did do is I did do a tympmastoidectomy and cartilage graft tympanoplasty and put a tube through there, and he's been doing well since that time. Okay, so that's all I've got. I'm going to just pause for a few minutes and see if anyone has any questions or comments about dilating and your experience with it. Yes, please.
Do you have any experience or comment about treating eustachian tube dysfunction as a result of radiation, either for head and neck cancer or brain cancer?
Yeah, those patients, I wouldn't dilate because they're probably so scarred down. A lot of those patients will have chronic ear disease as well. And so for those patients, unfortunately, you do a tube, and oftentimes, if that works and it extrudes, then I'll put in a T-tube, or I'll even do cartilage graft tympanoplasty. Yeah. Any other questions? Yes?
In cases where adenoidectomy causes scarring onto the torus tuberous causing dysfunction, I've seen 2 of those.
Yeah, so I have seen that, and for those cases, it depends. I usually don't dilate for those patients. They're better off if you can get back there and lyse that adhesion. And it just depends on how scarred up it is. I mean, I've seen cases where it's so scarred up, there's no way you're going to be able to even introduce something in to try to dilate. And thank you for mentioning adenoids. The other thing that you can see sometimes when you look in the back for these patients, even in patients who don't have a large adenoid, sometimes you will see some of that adenoid hyperplasia on the torus, and it partially obstructs the eustachian tube. And for those patients, I'll actually very gingerly just cauterize that tissue, and sometimes that's enough to get the eustachian tube to work. But if you see, in order to do the dilation, you have to be able to get the dilator in, number one. Number two, dilation, what you're actually dilating is the first 2 centimeters of the proximal eustachian tube. So it doesn't do very much at the level of the torus. So it doesn't work for, say, patients with cleft palate, right? Because they don't have the musculature to actually open up the eustachian tube orifice. So for those patients, it won't work. Also, I had a patient with primary ciliary dyskinesia, and they were referred to see me by another otologist who had tried to dilate. And for an underlying medical condition like that, dilation won't work either. Any other questions?
So we're going to have more with the discussion later in the morning about the eustachian.